So Dr. Coselli has developed over the last 12 to 15 years a technique which is a combination of open surgery and endovascular in order to treat the aortic arch where the disease goes down into the thoracic aorta. And to my huge pleasure, he's done this with a company in Scotland called Vascutek, now Terumo Aortic. And you're going to give us an update on the progress of that.
Yeah, I want to thank Dr. Ramaiah for really a fantastic meeting and the invitation. And for the recognition last evening, I was both honored and humbled. A lifetime award, though. I was reminded, I was with Dr. Cooley once, and a lady came up and she asked him if he had spent his whole life in Houston, and he said, well, not yet. So let's keep that in mind. I love AI. I'm excited about AI, but I'm still looking for residents and fellows who have intelligence, which is not artificial, but that's another story.
There you go.
So there's some disclosures here. There's room on this slide if you're out there somewhere. Hans Boris really gave us the idea of the elephant trunk technique and used it multiple different ways. The first frozen elephant trunk was really in Japan in 1996. Axel Havertz and his team in Hanover began to develop some handmade devices. Did it in 4 patients and reported on it with good results. But there's a lot of these things worldwide now, but the Thoraflex is the ones that we have in the U.S. I was involved. I was the PI for the trial for the U.S. It was approved in Europe in 2012, but it took another 10 years for it to get approved here in the United States. It comes in 2 forms. There's the plexus with multiple brachiocephalic branches, and then there's the anti-flow, which doesn't have those and has the flexibility of additional debranching with dependent upon the anatomy. It goes like this. You are on cardiopulmonary bypass, circ arrest, place it down into the descending thoracic aorta, deploy the stent portion, sew the cuff, and the cuff can be done. Here's drawing is back before, back distally, but you can sew it in 0 or even 1, and then depending upon the anti-flow or the plexus graft, you reconstruct the brachiocephalic vessels as necessary. And it can be done either way. It depends on the anatomy as needed. Here's an example of one of the cases that we did in the trial. It's an ascend. His descending actually been getting larger as well. We deployed this, switched the graft distally, and we used a plexus in this for the brachiocephalic vessels. In our own work, we've had a split of about half and half for those 2 different things, and then we extended it a little while later down to his celiac axis, and that was his ultimate result. This was done a number of years ago, and he's still doing well. Here's a more recent case from last week where you've got an aneurysm. He's got a previous Bentel operation. The arch has been getting a little bit bigger, but he's got this aneurysm involving the left subclavian and encroaches on the arch, and we put an elephant trunk graft in there, and in a 1-stage operation, everything is taken care of, and he went home yesterday. So we had the Thoraflex trial. It was 12 sites across the U.S., 65 patients in the primary group, 9 patients in the ruptured or the emergency group. We followed it out to 36 months, and these were all done in a couple of year period from 16 to 2018. In the primary group, which is the focus of most of this, it was 40% had aneurysm without dissection, 37 had chronic dissection, and only 1 had acute dissection. In the rupture group, which is kind of a mixture of an emergency cases, and I'm not really sure exactly how many of those were pure ruptures, but at any rate, there was the split, as you can see here, for those 9 cases. So these are the primary endpoints for those 65 patients. Early on, the all-cause mortality was 3%, but after year 1, the 11%, there was an additional 5 deaths. Permanent stroke was 6% early on, and there was some late strokes. Permanent paraplegia was very low, 3%. Unanticipated aortic-related reoperation was only 1 case. In the primary group, there were 26 planned secondary repairs, and it was almost all endovascular. Only 8% were done open. One of the 26 repairs underwent additional endovascular repair to treat an acute dissection with the rupture of the distal aorta to bail them out. In the rupture group, there were no planned repairs. Within the first year, there were 2 aortic-related deaths in the primary group. Both deaths were due to rupture, interestingly, of the downstream aorta. There were no aortic-related deaths in the rupture group. This is more of an international series of patients, and you can see the numbers are not huge, but these are all Thoraflex cases. reports anywhere from 2016 to 21. You can see the early mortality rate really varies from 0 to right at about 20%. Stroke rates are not insignificant here. As you can see, they're all fairly high. Double digits is not uncommon. Paraplegia is not 0, but it's actually fairly acceptably low. So this is a meta-analysis of almost 1,000 Thoraflex cases out of, and there were a fair split of almost 50-50 with dissection and non-dissection. In this particular report, the results were extremely good. The 30-day mortality was under 1%, and the overall mortality, which is in hospital as well as 30-day, was over twice that, though. Freedom from adverse events at 7 years was 94%. So the results were improving as we go along. So this is a 15-year outcomes from the group in Bologna. Their results were a little bit mixed. They had 186 Thoraflex cases, and you can see they had some renal failure, paraplegia. Stroke was 7.5%, and early mortality was 15%. This is actually fairly representative what we see out there. So when you get out and follow these patients over time, this is from a Marana in a meta-analysis in a group of 107 patients from their institution at 5 years. 40% required reintervention for distal. And this is from the international ones I showed you earlier about, this is a group of patients, point is they required reintervention for expansion and problems distally. Actually, in this analysis, there was no risk factors associated with reintervention, which makes identifying these patients somewhat difficult. So Terumo came up with this trial of extending things distally over time using the Relay Pro NBS, and there's a prospective multi-center non-randomized single-arm trial, 55 centers, minimum of 20 patients. The follow-up's going to be out to 10 years, and the study is actually underway. This is just some of the very early information on it with 68 patients. You got to remember this is a mix of Thoraflex devices and extension devices. The mortality all-cause was 11.8%. Deaths related to the procedure were only 7.5%. The 30-day mortality with the index procedure was actually 8.8%. Just very quickly, the Relay Branch platform has undergone its initial trial, early feasibility study, and it was idea is to take 30 patients with early follow-up to try to get the FDA to approve a further larger study, but they did allow this feasibility study to be extended out to 40 patients. And here's the results of this, and it kind of shows why this is kind of on hold right now. These early patients, the neurological events were 14, 46.7%. Only one was fatal, though, and about half of these resolved, but it's still very, very concerning to the FDA with regards to the total neurological events. However, if you look at these, the series that aren't involved, the other series of reported use of this device elsewhere, you can see they use the double quite a bit. Disabling stroke was not insignificant, 12%, 18%, 7%, et cetera. I will, however, say that in these series that these are high-risk patients, and so complications from their comorbidities are not totally unanticipated. We're going to hear more about this in a minute. So the FET is effective surgical treatment. Aortic reinterventions are common with endovascular-associated acceptable morbidity and mortality, and extending these devices are almost always endovascular, quite fortunately. So thank you for your attention.